multiple local voiding areas with two large areas seen at 32 and another area between 28 and 30 centimeters from the incisors. Biopsies from both lesions showed high-grade squamous dysplasia, and he's here today for an EGD with endoscopic submucosal dissection.
To find the lesion and to mark the extent of the dissection, of the resection. A very, very minute multifocal dysplasia. Histopathology showed high-grade dysplasia, and you see these small areas looking more reddish in TXI. You see here also. These lesions were also biopsied, so you have to be careful because sometimes when you biopsy those lesions, the lesion may disappear for a couple of weeks, especially if you perform Lugol plus biopsy. But you see there are changes in the vasculature, and also they look slightly more reddish with TXI. You see the extent here. The demarcation line between the lesion, and you see that in the normal squamous epithelium you don't see any IPCLs, but here with Tejari we agreed together that the limit was here. With NBI, the squamous neoplasia is seen as a brownish area because of the diffusion of hemoglobin in the epithelium. And also you have then those IPCLs that can be slightly irregular, and I think you may agree that some of the IPCLs in the middle are slightly irregular, so I would consider these, following the Japanese classifications, at B1. And we'll see if it works. Yes, it works very nicely. And then you start your cutting. I usually like to do the margin with undercut, because then the pathologist will be very happy with what I provide.
Yeah, do you pull?
You see, I use very little blue. In fact, blue is taking a lot of light off my systems. So, but what I did was almost a circumferential incision, except for a small part on top. And then I use my, so the jet from the scope. You see the multiple vessels here, although we are at 30 centimeters from the arcade, dental arcade.
So Pierre, you don't do the tunneling as...
well, it's a kind of tunneling, in fact, but it's, you see, I kept some attachment here on the top, here, so that I can glide my scope under the mucosa.
Would you consider traction techniques, clip-and-line technique, for example?
Well, I used that a lot in the past, but in fact, once you are using this technique underwater, you usually don't need it anymore.
Okay.
Because the traction is, you see, the specimen is floating here. And so I'm going to continue my dissection this way, because you see I'm exposing on the right, my knife is coming out from the left. And so I see what I'm cutting, and at some time, maybe in 2-3 minutes, I will cut the traction part here, and then it will float, and then it will be very easy to finalize.